All right, let's get started. Any questions from last time? We finished up our surgery meds, and now we're going to get into the last section for this test. It'll be the endocrinology section. Right? Have you guys been covering any endo elsewhere yet? Not even started it yet? Fantastic. I'll be your first exposure. So you'll be able to like just kind of just throw all this out whenever you actually get the real education on it, right? So, oh my goodness, back for more. All right, anyway, let's get started here. So let's talk about diabetes first. Is the Wilford Brimley diabetes meme still relevant with your age? Fantastic. Just barely, I imagine, yes. Fantastic. Think so? Okay. That's good. That's what I always think of when I think of diabetes, but and you're actually running people that say it like that, and you're like, you gotta take it seriously. Can't start laughing at them. Anyway, so looking at glucose homeostasis, we're going to see that there's several hormones that are going to be playing a role here. So what are some major hormones we're going to look at, do you think? Insulin's a big one. What else? Glucagon's going to be another important one, but there'll be maybe some other ones you haven't heard of. So have you guys heard of like glucagon-like peptide or GLP-1 before? Oh, yeah. That's one we'll talk about. Where'd you hear about that before? Biochemistry, okay, very good. We'll talk about some other hormones that will certainly be playing a role in terms of glucose homeostasis as we get into that. What do we use glucose for? Energy, right? We break it down, can turn it into eventually into what is the energy currency of the cell? ATP, absolutely, right. Now, certainly, we can use it for many other things. Carbon, oxygen, hydrogen can be used for lots of other things. You can find it can be turned into several other factors there. And you'll find that, depending on the situation here, that our ability to process glucose and our ability to handle it can be altered based on genetics, based on comorbidities, based on diet, a lot of different things here. You'll find that the body does require at least a very minimal amount of glucose per day. That's typically what the brain actually has to run off of. A lot of your other cells have the ability to run off of other things like fatty acid oxidation, amino acid oxidation, but really the brain has to have glucose in order to function there. But we're talking about diabetes. Obviously, this is that disease state characterized by hyperglycemia, right? So why does that occur? Why do we have hyperglycemia? Maybe you lack insulin, right? So certain types of diabetes may be resultant of having a lack of insulin, for sure. What are some other reasons? Yeah, we have a decreased ability to take in glucose into the cells to actually be used, right? What do you call that in terms of, not necessarily downregulation, but you tend to find, we talk about glucose sensitivity, right? So do they have a resistance to insulin? Do they have glucose sensitivity? Things like that we'll talk about. Now that's going to be playing a role. Why do we care about having high glucose? Is that a problem? Why? So we can talk about macro and micro sort of vascular damage that can occur here. So certainly things like cardiovascular disease will be hastened by diabetes, but I also see a lot of things like the neuropathies, the nephropathies that can develop for sure. So a lot of chronic conditions that can come about from this chronic hyperglycemia. And so we'll see some things we can do about that, some ways we can help them manage that. And certainly when you have patients who have metabolic syndrome and things like that, this is one of those things that kind of goes along with that. So hypertension, dyslipidemia, diabetes, they're kind of go hand in hand in a lot of these patients. So again, how do you diagnose this? I'm not going to get super specific into this, but I want to at least illustrate some of the things you might be looking for if your patient is hyperglycemic. But things we might look at includes, that classic triad of polyuria, polydipsia, and polyphagia for sure, but certainly doing our point of care glucose testing, we can also identify this. So for instance, looking at things like random glucose levels can be showing us the patient may have glucose intolerance at the cellular level. Fasting glucose can also be used, or we may even do things like glucose tolerance tests. Who do we do that in? Yeah, we do it in pregnant women typically, so we'll actually give them, and by all accounts, the glucose solution they have to ingest is like super gross tasting, and because they'll just basically just sugar and a little bit of Gatorade kind of flavoring, but we can go ahead and give them a big glucose load and see how they actually process it and see how well they're able to shuttle that glucose into the cells, okay? So as a result of how well the cells respond to insulin and how much insulin they're actually sending out in the first place. So familiar with the two main varieties of diabetes, you have type 1. What type of patients develop type 1 diabetes? Yeah, usually children, right? Because oftentimes, what's the reason why they develop type 1 diabetes? Yeah, it's usually an autoimmune reaction that they're having, and basically what is their immune system targeting? The pancreas, and more specifically within the pancreas, the beta cells, right, where insulin's actually being produced there. So you have this autoimmune reaction, you destroy those cells, and thus you have no insulin left to send out. This is important why you mentioned the pathophysiology, because it'll dictate what kind of medications we can use for these patients. So I'll make more clear points about that when we get into the actual drugs themselves. Sometimes you may have what they call like a type 1.5, which is more just kind of a late presentation sort of autoimmune sort of diabetes, not seen super commonly, but the majority you're going to be running into is going to be your type 2 diabetic patients, right? So why do they develop diabetes and hyperglycemia? Okay, so metabolic syndrome, diet. What does that mean? Like, why does that lead to diabetes? So I heard the cells are no longer responsive to insulin, right? So what happens when you have chronically high glucose levels? You want to get rid of that glucose by shuttling it into the cells. So what does your body send out a lot of to cause that to happen? What lowers blood glucose? Insulin, right? So that's your body's way of saying, hey, you need to get this glucose into the cells. That way we can get blood glucose back down to a normal level, right? So what happens if you're chronically hitting all those cellular receptors with insulin over time? They can't have that down regulation. That's where you get some of that resistance that actually occurs over time. So they get that glucose intolerance, or they get insulin resistance, right? Kind of two different ways to say the same thing, essentially. And so you're going to find that in those patients there, even though they may have sufficient amounts of insulin, compared to a healthy patient, it's just not as effective anymore, right? What happens to the pancreas over time when they're chronically just sending out all that insulin for years and years and years? Eventually kind of wears out, right? So they can become insulin deficient over time, but that's usually because they basically just wear the pancreas out, right? Too much wear and tear on the organ itself. Now, you'll see that in terms of type 1 diabetics, what percentage of them are going to need exogenous insulin? 100% of them are going to need insulin because they don't have any of their own to produce, right? And do you think they have any issues with glucose intolerance? Not typically, right? Because it's just the fact they don't produce the insulin in the first place. That's why they're hypoglycemic. The cells can respond just fine as soon as you give them insulin to interact with. But for your type 2 diabetic patients, I said 20 to 30% require insulin. So in some of these cases, we're either trying to give them extra amounts in order to overcome that resistance, or it could be some of those later cases there where you'll find that we are trying to replace what they may not be producing much of anymore. And so look at some different treatment strategies and how we're going to go about doing that. So you're going to find for the type 1 diabetic patients, not really any oral meds that they're going to be able to take a lot of advantage of for the most part. For type 2 diabetic patients, it's going to be mostly pharmacologic management and eventually transition over into insulin. So that's going to be the typical scheme of things that you'll see there. Certainly gestational diabetes can be an issue there. Certainly having this fetus developing in the woman can certainly put extra stress on the body, leading to that glucose intolerance. And then certainly we have sort of those pre-diabetic patients, which just have that impaired fasting glucose, which could be a sign of that insulin resistance starting up to develop. So typically with these type 1 diabetic patients, usually it's going to be renal failure that can lead to kind of chronic morbidity and mortality for those patients. Typically for type 2 diabetic patients, you know, the other cardiovascular complications they're going to have from their hypertension and dyslipidemia. Usually it's going to be cardiovascular stuff that's going to get them, or stroke or something like that. In terms of risk factors, you know, with type 1s, it's maybe familially related. We talked about a pediatric condition that can actually lead to diabetes. What was that? They have like a problem with like their pancreas like sending out their exocrine secretions. So yeah, remember that we talked about how the pancreas gets blocked up and then basically auto-digests itself. Like those patients can develop diabetes, right? Like we mentioned, they have insulin requirements. So there's a lot of different reasons why patients may develop that. For type 2, typically some genetic links in terms of ethnicity and things like that, but obesity, lifestyle is going to be number one cause for a lot of that. So looking at the pancreas itself, the big things I want to focus on for our purposes here are going to be the alpha cells and the beta cells here. The beta cells we've already identified as being the ones that will send out insulin. There's actually going to be some other forms there, things like proinsulin we'll talk about, sort of being like the prodrug version of insulin. We'll make some mention of that. When proinsulin gets metabolized, I'll show you a picture, it gets converted into insulin and C-peptide. C-peptide can be an important marker we'll talk about a little bit later on. It's kind of a more specialized sort of thing. But then the alpha cells are going to release glucagon, and what does glucagon do? Okay, so it increases glucose, but how does it do that? I hear a lot. Nothing unified in terms of like a good response there. So what organs are going to stimulate to produce glucose? The liver, right? The liver has lots of glycogen stores, and it's going to stimulate the liver to start breaking down that glycogen. glycogenolysis and then produces glucose from gluconeogenesis, right? So that's going to be one of the primary things you'll see with glucagon. The liver is going to be playing a big role there. So again, they're kind of the yin and the yang in terms of glucose homeostasis. As you'll see there, one will counteract the other. Will you ever see a patient with who's on insulin for their diabetes get glucagon? To save them? From what? Yeah, so hypoglycemia can be a thing here, right? So again, those patients may need either or in a lot of these cases. And in fact, a lot of patients who start out on insulin, we will give them a as needed sort of emergency dose of glucagon in case they get in trouble, because you're going to find that one of the big complications from using insulin and some of these other medication for diabetes, the number one most dangerous complication is hypoglycemia, right? And that is potentially fatal, so we want to make sure we're being very watchful for that sort of thing. Certainly we have our delta cells and our F cells, also important, but not going to be so important in terms of our uses today. And you can kind of see the changes that occur over time, where these patients with diabetes are going to end up developing they'll have this autoimmune destruction of those beta cells if they're a type 1 diabetic, or you'll find with type 2s, again, they're typically overusing the cells, and eventually they just kind of wear out, just like other things in the body will do over a period of time there. You'll also find as well is that patients with diabetes, especially like type 2 diabetes, they're going to have altered responses in terms of how they're going to be secreting these hormones. So they may have issues to where, say for instance, like you eat a big starchy meal, so say you went and had like a big bowl of cereal or something, what would you expect your insulin levels to do in response to that big glucose intake? It would spike up, right? What would you expect glucagon levels to do? They should go down, right? Because your glucose levels are high, it shouldn't need a lot of glucagon to respond to that. Well, what you're going to find with these patients, especially with type 2 diabetes, is the fact that they will have inappropriate responses here where glucagon levels will stay high, or insulin levels may not spike up like they should, and because of that, you're going to find they will have, that will kind of further worsen the issue, and you're going to see that also will lead to higher glucose levels, and we'll find some ways to deal with that. And so what you'll find is that our typical patient with diabetes will have a lot of reserve in terms of pancreatic function, such that it may be pretty well gone in terms of percentage of function lost by the time you actually make the diagnosis itself. So in this case here, about 50% reduction in function before the actual diagnosis, before the actual hyperglycemia was ever noticed here. And so our goal is, one of the things we'd like to do is try to prevent further loss of pancreatic function as best we can. So we're going to try to find some ways to try to resensitize the body to insulin, such that your cells are going to be able to be better suited to take up that glucose. And we'll look at some ways we can manage that with our medications in just a bit. So as I mentioned, with type 1 diabetes, mainly going to be sort of an autoimmune condition, but there could be other ones like CF, as I mentioned there, other sort of forms. Again, these are going to be patients that will absolutely have to have insulin as a replacement because they don't produce any on their own, or at least enough to really cause a significant effect to get that glucose under control here. How do a lot of these patients typically get diagnosed? Yeah, they may be presenting with DKA for the first time. So we'll see them in the ER. You may have like a patient you have no idea has any issues come in. Maybe they're 6 or 7 or 8. They're coming in and say for altered mental status or something, or maybe they're just really huffing and puffing. They got this kind of fruity odor on the breath. This kind of typical presentation. That will be like kind of a new onset diabetic, and you'll be able to kind of catch that. We'll talk about DKA a little bit later on, how we kind of manage those patients there. Yes, sir.
Do you know why we see that? Like you said, like 6 or 7 versus like when they're a neonate?
It could be because they may have not have developed a big enough immune response to actually, because remember you saw that like there's a lot of loss of function before you actually get to the point where you're really hyperglycemic. Just like with our kidneys, like you could remove a kidney, you can still have pretty normal function for the most part. We have a lot of excess function there to kind of pick up the slack, so to speak. So it could be related to that. Maybe it's just kind of a steady decline in function over time. That's just now when we found it, right? So it could be an issue with that. You'll find some patients will even present a little bit later on when they get found out, so it just depends on the patient themselves. Anyway, so let's get into insulin specifically. So insulin itself is going to be, again, a prohormone that's going to be made up of, basically it's proinsulin. It gets broken down into this insulin and C-peptide. And I'll show you a picture of what that looks like in a second here. C-peptide itself doesn't have any known function, but it's actually nice because we can use that as a measure to see how much insulin secretion the patient actually has on their own. If you can measure a blood level of C-peptide and it's low, then the patient's not really releasing a lot of insulin. If it's high, then that means yes, they are releasing a lot of insulin in those cases. It's kind of a specialty lab you may see your endocrinologist using potentially. Basically, you're going to find that insulin itself gets cleared mostly through the liver, but there's a significant enough amount that actually gets processed to the kidneys, such that you may actually find even though it has a relatively short half-life, in patients with renal dysfunction, they may be prone to hypoglycemia because they hold on to that insulin for longer, which can then interact with the cells and cause that glucose uptake to occur. So one thing to consider there is what's the patient's renal function in terms of how well can they clear this insulin. So what happens, how do our cells know how do those beta cells know to release insulin? So glucagon will inhibit it for sure, but like how does the body know to release insulin in response to glucose? So it's actually kind of a cool process. Not only we'll go in the weeds on this one because some of our medications can actually interrupt this process and can modify the amount of insulin we're releasing in the first place. So I'll show you a picture of this in a second and kind of make more sense. So let's say we have our pancreas and you're exposing it to glucose. So you just had that big bowl of, I don't know, Cinnamon Toast Crunch, probably like 99.999% sugar, right? Intaking that, blood sugar skyrocketing, it's sitting there like 400. You're sitting there eating your cereal, watching your morning cartoons. Maybe SpongeBob, I don't know. And so what will happen is you'll actually have these glucose transporters sitting there on the beta cells. Glucose transporters are obviously going to transport glucose. Glucose comes into the cell, and what does the glucose do when it gets in the cell? It gets converted over to ATP. So now we have energy, right? Now we have these energy particles here, and that will actually go through the TCA cycle to get developed there. What happens now is now we have this increased ATP. It'll actually end up closing down these potassium channels, right? So you have these potassium channels will be closed as a result of exposure to ATP, and what that does is it actually will cause the cell to become more positive, right? Because normally potassium is in a higher level in the intracellular space than it is on the extracellular space. So you're decreasing outward flow of potassium. The cell's going to then depolarize, right? So it's going to have a depolarization, and that allows for voltage-gated calcium channels to open up. Now calcium can flow in, and calcium will actually stimulate release of these vesicles that are full of insulin. So calcium comes in, you'll then release these vesicles of insulin out into the bloodstream, and thus that should be able to bring your glucose back down to somewhat normal levels, right? And again, when the glucose levels are down to somewhat normal, then that intake through those glucose transporters will slow down, less ATP is being formed, and so you can see how it's kind of sort of a negative feedback loop to make sure you're not just sending out all the insulin you have, because then that would cause pretty significant hypoglycemia, right? So the only reason why I mention this is maybe because you're going to see where our sulfonylureas, which is going to be one of the core sort of medications we're going to use for these patients, will come into play here. And what they can actually do is block those potassium transporters themselves. So instead of needing ATP and high glucose to do that, they can actually directly go in there, block up those potassium channels, and guess what? Same thing happens. Insulin gets released as a result of that calcium influx. So here's what this would look like. So say we have our glucose coming in through the cell, these glucose transporters, metabolized to ATP. That'll close down these potassium channels, so this is no longer sending K out of the cell, right? Because it's high concentration in here. So then it causes a depolarization, calcium comes in, and then will stimulate exocytosis of these little vesicles full of insulin. And that should bring down your glucose back down to normal levels, right? So what happens when you release that insulin? What does it do to the cells to actually change your blood sugar levels? Well, basically there's going to be several different types of glucose transporters throughout the body, which insulin is going to have an effect on, as you'll see. Basically, when insulin interacts with insulin receptors on the cells, it will cause more glucose transporters to be sent out to the cell surface. So more glucose transporters on the cell surface will allow more glucose to come in, such that your blood sugar is going to be lowered because all these cells are basically taking it up, right? They can use it for energy, they can use it for all sorts of things there, right? So, and then if you were thinking about like insulin as being like, say, like a catabolic versus like an anabolic hormone, what would you consider insulin to be? Actually anabolic, right? And so you may actually find that this can be a useful thing because not only are you getting glucose coming in as a result of insulin, but things like amino acids and things like that can come in. So you may see like bodybuilders or somebody actually using insulin in order to put on some mass because it actually helps to bring in glucose, helps to bring in amino acids, and they can actually make the cells bigger and stronger essentially. What happens to glucose that doesn't need to be used for energy right at this moment? It gets stored as glycogen in some cases, or what's another way it could be stored maybe for even longer term storage? Yeah, it turned into fat eventually, right? It can be turned into fatty acids, be incorporated into adipose tissue. So those are kind of the two places you're going to see that. And that'll become important in terms of fatty acid oxidation when we talk about DK8 and how that is going to be an issue there. So looking at this, you can see we have these tyrosine kinase receptors that insulin will then bind to. Sorry, my mouse is not working. Insulin will then bind to this, and that's going to cause a whole lot of downstream effects to occur there, right? So it's not just these glucose transporters, but that's going to be our most important thing we're going to focus on. But basically, you're going to find that's going to cause these glucose transporters to be translocated up into the cell surface unless you have more glucose coming in, right? So it can either be used for ATP, can be stored for glycogen, can be used for all sorts of different things there, right? So if you were to have, say, a lack of insulin, then what would happen to those glucose transporters? They're just going to stay within the cell surface, and then this glucose can never make it in, right? So that would be someone like your type 1 diabetic patients who don't have any actual insulin itself. Or you may find that you have downregulation of these insulin receptors, right? You may find that you have just fewer receptors for insulin to interact with, thus making it more difficult to get those transporters up there, and that can also lead to your hyperglycemia in your, like, say, for instance, type 2 diabetic patients, right? So different ways for the same thing to sort of happen, even though the mechanism is quite different between the two. So I'm not going to get into the weeds in terms of your different types of glucose transporters, but just know there are different varieties located throughout the body. So for instance, like in the brain, like glucose 1 transporters are really important, glucose 3 transporters. There's a lot of different varieties that are out there, but essentially they all are going to work the same, okay? So then other effects here we're going to see in terms of the effects on the liver, right? So let's like say we're talking about skeletal muscle cells before, other types of cells. Now we're going to be focusing on the effects on the liver here. You're going to see that this is going to stimulate uptake of glucose into the liver, and that's going to get stored as glycogen, right? And that'll be important in terms of when we need to have gluconeogenesis happen later on to release that in, say, response to something like glucagon. So again, the liver is really important for storing glucose as glycogen. And so this will also have an effect on things like adipose, or conversion of a lot of those fatty acids into VLDLs and cholesterol and things like that. So it's also going to be another stimulatory sort of effect here. And remember that these are going to have sort of seesaw sort of effects or inhibitory sort of effects here, such that insulin is going to inhibit glycogenolysis, right? Why does that make sense? Because it's stimulating glycogen synthesis, so you wouldn't want to say break down glycogen because you're already in a state where you have a lot of extra glucose, so you're storing it in the liver anyway. And then it will also inhibit this conversion of fatty acids into ketones, which is, again, is another important reason why this is going to be the treatment of choice for DKA for those patients that are insulin deficient, as we'll see later on. In terms of skeletal muscle, as we were talking about, again, storage as glycogen, but also used as a building block for lots of other things, amino acids, etc. And then in the adipose tissue, it's going to stimulate that storage of fatty acids as triglycerides and add to that fatty acid store, right? So you can use that for kind of long-term storage there. Remember how many calories were in every gram of fat? 9, right? Because again, you're kind of attaching a lot of different fatty acids together, so there's a lot of carbon there you can get energy out of. So looking at insulin release, how does our body actually send out insulin throughout the day? You know, does it only get sent out in response to food, for instance? Well, no, we always have a basal amount of insulin our body is releasing all the time, right? So you'll find that it'll go through these sort of peaks and valleys. So for instance, let's look at our basal glucose levels on this line here, and then our basal insulin levels. You always have a very low amount of insulin around, and that will help to regulate what that basal glucose is, right? So basal glucose should be roughly what? Say at a fasting state. 0? 0 good number for glucose? No, they'd be dead. No, you don't want that. Usually what? 80 to 100-ish, somewhere around there, right? Depending on the patient, but let's say somewhere around that number there. So what happens when you have, say, a big influx of carbohydrates, say, during breakfast? Well, glucose levels are going to go up, and then your pancreas is going to send out more insulin in that case, right? Glucagon levels should diminish as a result of that as well. And so you're going to see that you'll get this big spike up during breakfast time. And then say you have lunchtime, maybe you have like a light salad, so maybe not so many carbohydrates in there. So you maybe get less of a spike in that point. And then of course dinner time. Again, the main point being is that you're going to always have a basal amount of insulin around, and then you're going to have spikes of insulin in order to deal with carbohydrate intake due to diet, okay? That's really important for patients who are, say, type 1 diabetic patients who are actually going to be replacing their insulin because they're not making any of themselves, that we're going to need something long-acting to provide that basal amount of insulin, and then we're going to need short-acting insulins to account for meal times, okay? So we'll talk about this basal bolus sort of approach and how we actually deal with that in just a little bit. So in terms of insulin formulations, there's a lot of them. There's like roughly 17 or so that are available on the market. The differences between them, and you should know the differences between them and identify the different types of insulins. Is it short acting, long acting, etc.? Because this is really important in terms of like which ones your patients are getting, to be able to identify that, how they're dosing it. Is insulin an inherently dangerous drug? It is one of the most dangerous drugs you might be dealing with on a day-to-day basis. It is easy to kill a patient with insulin if you screw it up. Do hospitals ever screw this up? It's not great. We try not to, and we put a lot of safety features in place to prevent that from happening, but it happens, and I'll talk about some different ways that that can actually occur. So, we're going to see that the pharmacokinetic profile of these insulins can actually change quite drastically. We can do things like change out the amino acid sequence of regular insulin and turn it into something different. Maybe it works faster, maybe it works slower. We can do things like adding zinc to it. Adding zinc to it tends to make it have a longer duration of action because it affects the solubility profile. Adding protamine may actually affect that as well, right? So remember we talked about protamine before. Where did we talk about that? Yeah, it was an antidote for heparin. This is the same protamine molecule, and in fact, if you have someone who has a protamine allergy to insulin, or has a protamine allergy, say that they got it for heparin use, they may actually have issues with some of these protamine types of insulin. So you may hear a patient have an insulin allergy. It could be related to something else that's actually formulated with that, right? So we'll talk about that later on. And then as I mentioned, we'll talk about some analogs where they actually change the amino acid sequence. So here is what, say, proinsulin would normally look like, and then what happens here is the C-peptide actually gets cleaved off, and then you have these two disulfide bonds. So this darker blue portion here is what normal human insulin actually looks like in terms of like the amino acid sequence here. And so you can see here, just by changing out a few of these amino acids, you can get completely different profiles in terms of how fast or slow the drug actually works here. So for instance, if I were to change out protein 28 and 29 here to lysine and proline, you actually get insulin lispro. That's actually where the name comes from, and you actually see that it actually works a lot faster. Or for instance, if I change out this asparagine perhaps for a glycine, I get insulin glargine. It's that long-acting insulin right now. Now, it is tough for some students to memorize this entire amino acid sequence, but I have faith in you that you can do this. Just kidding, I'm not going to do that. But you should be able to identify the different types of insulin. I'll show you a table that will compare them, and you'll have a good feel for how the different profiles and how they're actually working. Now, why do I put bovine insulin on here? Where's that coming from? From cows. Why would I have that? It's where we used to get insulin from, right? So before, back in the day, we did not have synthetic ways of producing insulin ourselves, and so it didn't seem like a nice idea to harvest it from people because they needed their own insulin, but we got it from animals. So there's bovine forms that we used to take. And again, very similar in terms of amino acid sequence. So guess what? It worked pretty similar to how it does in humans normally. Anyone know another source of insulin we used to get it from? From pigs. So if you ever see porcine insulin, that's where that came from as well, right? Could that be an issue for any types of patients? Yeah, so if they have like religious considerations, you could potentially give it to them. So if they had an issue with pork or beef potentially. Luckily nowadays, we don't have to worry about that so much anymore, but you never know, sometimes it could come up. So getting into it, so as I mentioned, you used to get it from beef and pork products anymore. Obviously it was not ideal because anytime you're injecting animal proteins, there always is that risk for anaphylaxis, right? And again, how would I give these insulins? Can I give it orally? No, they're proteins, I can't do that, right? So most of them are gonna be given via injection, right? Mostly sub-Q injection, IV injection potentially. There's actually one inhaled formulation we'll talk about very briefly here. So there actually is a way to get that insulin protein actually absorbed through the lungs, but we'll mention that. Pretty rarely used product here. You can still get some porcine insulin. It's for patients who maybe cannot tolerate normal varieties of insulin for whatever reason. I've never actually seen an order, but it's available. Probably pretty expensive if I had to guess. Nowadays we use recombinant insulin, usually made either from like yeast particles or E. coli. Basically they've been engineered to produce human insulin themselves. So kind of a modern marvel of science here that we can actually produce our stuff. So, and actually the two main varieties of insulin are actually made by two different brands here. So for instance, the E. coli variety is going to be called Humulin. Those are actually made by Lilly Pharmaceuticals, right? This is actually not the same way I spelled my daughter's Lily, and that actually was just a coincidence. My wife just happened to really like that name, but it was not due to the pharmacy company. In terms of baker's yeast, this one actually comes from where Novolin comes from, and Novolin's a Novo Nordisk product. So again, it's just a matter of how they actually produce the stuff. They actually work identically to one another, so we'll look at some varieties there in just a minute. If you guys recall, remember I was talking about that family in Kentucky with the inherited methemoglobinemia? Well, just to, you know, I think karma works in mysterious ways sometimes. I get home, and guess what my daughter's wearing? She's wearing a wife beater. I said, where did she get that from? She's like, I don't know. It was like in the dresser and just put it on her. And I was like, she looks like she's 6 months late on child support. Like, what? not great. So I was like, well, she's from Putnam County originally, so that makes sense. So anyway, so here's here's the different varieties of insulin we're going to run into. Remember, it's going to be based off of their profiles and how fast or how slow they're going to be acting or how long they're going to be acting for. So we're going to start off with the ultra short acting insulins here. So do you think this is going to be good for more like basal kind of amounts of insulin, or are they going to be good for end result or as a due to glucose intake, say due to meals? Yeah, these are going to be good mealtime insulins because they're going to work pretty fast. And I'll show you the kinetics in here in just a minute. So if you ever see like insulin Lispro or insulin Aspart or insulin Glulicine, that always will be preceded by the insulin. So you always know it's insulin at least, but you need to be able to identify if they're short acting, long acting, etc. Those are going to be ultra short acting. There's also what we call just regular insulin. So like if you see Novolin or Humulin, that's just regular insulin. That means it's very similar to what we produce ourselves. It should act just the same as our normal insulin would. Okay. Then we're going to get into some of our intermediate acting. So things like NPH. That's not Neil Patrick Harris, but it has to do with protamine. That's included in that. So that's going to be a more intermediate acting one. And then we actually have some of our long acting agents here. So the intermediate to long acting ones are going to be better for sort of that basal amount of insulin throughout the day. Maybe it's just one-time injection, maybe a two-time injection a day. It's going to be able to provide basal control for glucose. And then we're going to use a short acting or regular insulin on top of that for mealtime influxes of glucose. Okay. So for the ultra long acting, we have like Glargine, Detamir, and Degludec. For the long acting, we have Ultralente. I will tell you the most common ones you're probably going to run into nowadays, at least what I see, is going to be the ultra short acting, the short acting here, just the regular insulin, and then your ultra long actings like Glargine, Detamir, and Degludec. I'm going to show you the brand names here in a second. You've probably heard of some of these in your journeys through life at some point. There's also the inhaled form, which is going to be Afrezza. This is going to be a very sort of niche sort of use for patients who maybe don't want to inject themselves, which again, having to say you're going to inject yourself the rest of your life is not an ideal sort of thing. This may be an alternative for them potentially. So, and you can kind of look at the different release characteristics for these drugs and how they're going to work differently from one another. So for instance here, if you're looking at time in terms of hours, and then you're actually looking at the glucose infusion rate. So this would be basically how much glucose you'd have to administer in order to maintain a normal steady state of glucose, right? So say around 100 or so. For the ultra short acting, you can see here that their activity spikes up pretty quick, right? So that is good for, say, right around mealtime, maybe 15, 20 minutes beforehand, or maybe even during the meal, they can inject this and they should be able to control that big influx of glucose. Versus something like your regular is going to be a little bit, has a little bit later peak there, so maybe they'd want to take this maybe an hour or so before eating in those cases. And then you have your long acting formulation. So for instance, something like insulin Glargine, I can just give one time a day and basically will provide 24-hour coverage for that basal insulin need for those patients there, right? And then, so typically they're going to be on a basal bolus sort of schedule that may have a basal dose they receive one time a day, and they'll be on at mealtime insulin doses as well. And I'll show you what that looks like in a moment. So there's different ways to give it. We mentioned injection is by far the most common way you can administer that, but certainly this can either be drawn out of a vial, or many times it'll come in a pen formulation, meaning you can actually dial in the dose at the end, put it on a pen needle, and then just press the button on the end once it's injected into the skin. Where do patients most often inject this, do you think? Yeah, usually the stomach, because again, just ease of use. Again, this is another important thing to make sure they rotate sites and not inject into the same spot every single time. Scar tissue can develop and get more painful. Lipodystrophy can occur, so you want to avoid that, right? Now, this is actually a picture of the actual first insulin pump that was ever made. Can you imagine carrying that thing around? It's like, yeah, I don't have to inject myself all the time, but I got to carry this big honker around, right? Not ideal. Nowadays, this is how big they are. It's like basically the size of a pager. Now, I know most of you probably don't know what a pager is, but it used to be this tiny messaging device you'd have to wear on your belt in order to get notifications from, say there's a trauma coming in or something. So actually, during my fellowship, we still use pagers everywhere because a lot of parts of the hospital are basically deadened to where they can't get cell signals in, but pagers still work, so you may still run into those occasionally. But anyway, this is a nice tiny pump that will actually be loaded with insulin. There's a reservoir in here for insulin, and there's a sub-Q catheter basically that will be constantly sending out small amounts of insulin throughout the day, and then the patient can bolus themselves around meal times. So what's the benefit, do you think, of using a sub-Q pump like that? Yeah, compliance. They don't have to inject themselves all the time. And what's really cool is actually, we talk about these type 1 diabetic patients that are younger. They get really, really good with this. So whenever we have patients who are coming in for, say, they're either having pneumonia or whatever the reason they're coming in, say they're on an insulin pump, one of the things we have to do is go up there and make sure they know how to use it and everything, so that way they don't accidentally like overdose themselves and they're hypoglycemic. And so I'll talk to them and be like, okay, so how do you do this? How do you calculate this stuff? And they know everything about their diabetes. They know exactly what they eat, how many units of insulin they need to get. They know how to do all the calculations, and they're like 9 or 10 years old. I'm like, I couldn't do any of that stuff. I could barely like wear matching clothes when I was like that age, but somehow these kids have got it. So that's pretty cool. And then you have your inhaled insulin here. Here's this, basically it's a dry powder the patient can inhale. Again, pretty niche use, but I just kind of mention it just to give you an example what that looks like. So this is a good slide here to kind of get familiar with some of the brand names of insulins you're going to run into. Now, I don't really care that you know the different options here in terms of how they're available, but it just gives you an idea of, do they come in vials? Do they come in pens? Do they come in different formulations there? But it's a good idea to get familiar with the different types of insulin and their brand names as well, because you're going to run across that pretty frequently. So for instance, you have like Humalog, which is insulin Lispro, a very short-acting one. The alternative to that would be the Novo Nordisk version called Novolog, which is going to be insulin aspart. I think like log, I think logarithmic. It makes me think fast for some reason, kind of increasing quickly. So that's how I kind of think about that. Okay. So Humalog, Novolog are going to be a really fast-acting one, and then the newest one out of this group is called Apidra or insulin glulicine. Now you'll find that in a lot of hospitals, they will pick one variety or the other as kind of being their formulary option. So for us, like we only use Humalog products. We use Humalog, Humulin. That's just what we got a better deal on, and so that's what we go with. And so frequently we'll have patients who may be on Novolog, and then we'll have to convert them over to the other products. So that may be something you run into with your patients. There's that. There's the short-acting insulins, which is just regular insulin like what we produce. So Humulin and Novolin, those are your regular acting insulins. Then you have your NPH insulins. You can always tell it's an NPH because it'll have an N after the end of it. So you know it's more intermediate acting, maybe say 6 to 12 hours sort of duration of action. And then your long-acting, so your Lantus, which is insulin glargine, your Levemir, which is insulin Detamir, and then Tresiba, this is the newest one out of this group, called insulin Degludec. Okay, so be able to recognize on a test or to say, hey, patient, needs a mealtime insulin. Which one of these would be most appropriate? You would not want to pick insulin glargine because that's a long-acting. You wouldn't want to do that. But something like insulin aspart would be a good option. And I'll have the brand names there, of course, so you'll be able to identify it based on that.
I can't think of a reason why you want to use an intermediate over a long-acting other than maybe price.
So for a long time, that was all we had was the intermediate acting. So those are older. You still may find use cases. I can't think of any off the top of my head where that is more appropriate. Probably 99 times out of 100, they'll probably be on a rapid acting and then a long acting insulin. Yeah.
It's used for all patients who can't afford the other ones. Like
Sure.
Walmart is super cheap.
Okay, yeah, so it could be an alternative as well. So again, I don't want to get into insulin pricing, but it's ridiculous. Yeah, the whole thing is quite silly. If you look at the cost to actually produce it versus what they charge, it's nonsense. But regardless, I'm not going to get political here, people, okay? Although, who should vote out of this room? Everyone should vote. I don't care who you vote for, but vote for somebody, right? November is coming up. Anyway, that's my soapbox. But you may also find there's like actually some premixed varieties as well. So they would actually combine two together. So for instance, you'd have one that has a protamine insulin, which is more intermediate acting plus a fast acting, right? So maybe that would be good around breakfast time to deal with the breakfast glucose that's coming in, along with providing that basal insulin amount for say that next 12 hours or so, right? So there's some mixtures there. There's just NPH and regular insulin varieties. Now, one of the things I will note here in terms of the nomenclature for your insulin dosing. So we don't dose insulin in milligrams or micrograms. That was going to be based in units, right? So you want to keep your units straight. So when I say U100, that is the standard insulin concentration you're going to run into. U100 means there's 100 units of insulin per ml, okay? Now some patients, especially with if you had to imagine, so say you have like a type 1 diabetic patient who doesn't have any insulin that they produce versus a type 2 diabetic patient who's basically worn out their pancreas from chronic hyperglycemia, which patient do you think would require a bigger insulin dose? Probably the type 2 diabetic patient because they develop a lot of insulin resistance over time. I've had patients who have required such huge doses of insulin that giving them the U100 just really wasn't that feasible because we were going to burn into our supply. So sometimes you'll actually find we can use a more concentrated formulation. So there's like a U500 or a U200 version. It's really important to ever take that into account if you see that, because guess what happens if you screw it up and you are dosing based off of the wrong concentration? Best case scenario, you underdose them and they remain hyperglycemic. Worst case scenario, you give them 5 times the dose potentially. Guess what? Now their sugar's like 2, and they got to give them glucagon and dextrose and try to get their sugars back up. So again, this is something that happens. You got to be really careful in using your insulins, especially anytime they're on non-standard concentrations. Okay, this would just mean there's 500 units per ml versus the U100, which is 100 units per ml, right? And again, whenever you see like an insulin syringe, those are based off of units, and that's based off the U100. Okay, far and away, that's the most common one. Okay. And then like the Afrezza comes in like either 4-unit, 8-unit cartridges. I don't know who named it Technosphere, but I thought that was pretty cool. So something you don't see too often. Now in terms of their pharmacokinetics, again, I just want to kind of show you sort of the trends here, not necessarily memorize the exact numbers, but looking at things like Aspart and Lispro, notice they're very fast acting in terms of their onset. Within 15-30 minutes or so, it should be kicking in. And again, it's one of those things where, you know, if a patient's having a meal, yeah, they can take it around meal time, maybe right beforehand, and it should be able to counteract that. What would happen if a patient, say, has an order for insulin aspart 3 times daily with meals, but what if they skip lunch for whatever reason? You just skip that insulin dose too, because guess what? If you give it to them anyway, they're going to get hypoglycemic. So it may seem like common sense, but again, common sense is not quite so common as you might imagine when you get out there in the real world. In terms of duration, pretty short acting for the most part, right? Getting into regular insulin, which is probably, if you're gonna find one that is most frequently used for, say, like insulin drips, or if you're gonna use this, say, for like a DKA patient, most often it's gonna be a regular insulin drip. So this still gets used quite frequently. Again, slower in onset, later, you know, more delayed peak, but can still be reasonable to be used around meal times. Again, you probably wanna use this one maybe 30 minutes to an hour before the patient would ingest their carbohydrates, right? To make sure that it gives it enough time to actually counteract that. Intermediate one's gonna be longer, but again, I wanna focus on the long-acting varieties here. Again, their onset's gonna be pretty slow, but we don't need it for its peak effect. We need it for that long-lasting effect throughout the day, which is good. You can see here it can last, you know, up to 24, 36 hours in some cases there. So that's what we're really using it for that basal replacement of insulin that the patient needs. So as I mentioned, be wary of the concentration you're dealing with there, whether it's U100, 200, etc. There could be some issues that develop here. So patients may actually develop a true hypersensitivity to the insulin, because again, it may not look exactly like human insulin in terms of amino acid sequence, so that is a risk. Some people even actually develop an immune insulin resistance, meaning we actually, just like say for instance with like infliximab, remember that you could have acute anaphylactic reactions to it, or you could have more of a reaction where the antibodies actually just neutralize the drug over time, make it less effective. Same thing can happen here, where your insulin will lose efficacy over time as a result of that. Now this is not something I want to give methotrexate for to prevent, because they wouldn't have an indication for it, but it's something just kind of keep in the back of your mind. If the patient says they're being compliant, but their glucose is still high, it could be as a result of that potentially. And you can try switching insulins to get it around that, right? Other things, how do you store insulin? Typically in the fridge. Actually, you can store it at room temperature once it's open for like 28 days. But you have to consider, like, proteins are inherently sort of unstable, right? So you'll find that if you, say for instance, you have a patient goes to the Walgreens, say it's like July, pick up their Pharm, their insulin, and they just leave it on the dash when they go shopping. They come back, what happens to that insulin? It's going to denature, right? Because again, the heat is going to be a problem for that. So you definitely make sure you educate, hey, don't leave this stuff in your car, especially in Florida, it can be a big problem for that stuff. But typically in the fridge is where most patients will keep it. It's important to warm it up, at least kind of roll it in the hands and the palms. Try to warm it up some. It will not hurt as much when you inject it, for sure. Don't shake protein containing solutions, because anyone know what happens? They foam up. And that foam is all that protein coming out of solution, and it's not really there in the actual liquid to treat your patient anymore. So don't shake protein containing solutions there. As I mentioned, the lipodystrophy is going to be a thing you're going to see, so make sure they rotate sites to avoid that. And then weight gain is obviously going to be a big risk. And so we're going to look at that in terms of the other meds we'll talk about, in terms of which ones are going to be weight neutral, which ones may actually help you lose weight, and which ones will actually cause you to gain weight. As I said, insulin is an anabolic hormone, steroid essentially, so you're going to find that it will cause weight to go up, okay, as a result of that. So this is something we may want to be wary of. Now, like a typical type 1 diabetic patient, are they typically over or underweight? Usually kind of underweight, because again, they're not shuttling that glucose into their cells like they should. So it may not be a problem for them, but if you imagine Wilford Brimley getting his insulin, is that going to be a problem? The diabetes? Yeah, that might be a problem, right? Because if they're already overweight to begin with, that can be an issue there, to where they're putting on more weight in those cases. So we'll look at some ways to counteract that a little bit later. So there are medications that may decrease the efficacy of our insulin. So a lot of medications can do this. So for instance, like corticosteroids, like why would that decrease the efficacy of insulin? Not necessarily. What do corticosteroids do to your glucose levels? They increase it, right? Because against the stress hormone, so you're going to see that actually will increase glucose levels. It will counteract that. So really, you're going to see this kind of functional antagonism, or anything that raises glucose levels will automatically be in contrast to insulin to make it less effective. I need more insulin to get around that. I may need to up the dose in order to handle that. So anything that's going to be stimulating the sympathetic nervous system, because that will directly stimulate the glucose to make more, the liver to make more glucose. So things like epinephrine, dobutamine, all of that can certainly do that for sure. Even things like thiazides could have a reaction here to see increased glucose levels. So little things you want to be cautious with. Again, if you're not sure about a drug interaction, what do? Look it up, right? I was so heartened. One of our former graduates was here helping out with the behavioral sim, and I was talking to her about her work now in the ER, and she was like, yeah, I look up everything I'm not sure about. Even if I'm really sure about it, I still look it up. And I was like, yes, that's so great. You should always look up stuff. Anyway, some things that actually will increase the hypoglycemic effects of insulin can be things like anabolic steroids, beta blockers. As you might imagine, beta blockers will block beta receptors on the liver and prevent gluconeogenesis from occurring. Right? So that could be one thing. And remember, what do beta blockers do to the symptoms of hypoglycemia? They mask them, right? So that can be definitely a big interaction you'd want to watch out for and educate about. But like alcohol is another big one. I'll never forget one time I was in undergrad, and I was at someone's house. I don't remember what the situation was, but I was just kind of stopping by. I remember there was a party going on. I was not participating at all. But I remember there was someone who was in the same dorms as me, and I remember she's a type 1 diabetic, and she was, she's insulin dependent. And I remember her doing shots, and I was like, I'm pretty sure you shouldn't be doing that together with your insulin. She's like, it'll be fine. I'll just make sure I get a Jello shot that has more sugar in it, and it'll be okay. I said, okie dokie, and then I left and not participate. But point being is that alcohol can be a problem there, because again, it can deplete glycogen stores of glucose in the liver, so you do want to be cautious with that, okay? Now, when would I give insulin? What would be the indications here? So one would be any newly diagnosed type 1 diabetic patient. Obviously, they are requiring it because they don't produce any of their own or very much. You'll find that for patients who have gestational diabetes, this is probably the safest medication to give them, mainly because it's as natural as what they're producing themselves, so that can be reasonable for them. In that type 2 diabetic patient, if medications have failed and other non-pharmacologic methods have not been successful, then you consider adding these patients on insulin. In a lot of cases, they may be insulin dependent the rest of their lives, depending on if they are not able to get kind of their weight under control and things like that. DKA, or diabetic ketoacidosis, this is the treatment for that, because again, this is in some cases either non-compliance with a type 1 diabetic patient's regimen, or this is the first diagnosis, but they are severely insulin deficient. And again, what happens, why do people get DKA? Like, what's the underlying issue there? What happens? Because they're insulin deficient, so they can't shuttle glucose into the cells, but the cells still need energy, so what do? Break down fatty acids, right? And so as they start to metabolize those, start to produce things like ketone bodies and acetone and other things. And so like what happens to their pH? Well, it's diabetic ketoacidosis, so presumably they get acidotic, right? So you can find like really significantly lower pHs. Like a normal pH is what in the serum? 7.35 to 7.45, right? These patients will come in with like a pH of 6.9. That is not normally super compatible with life. So the biggest thing you can do for those patients is to, one, get their pH back up. Sometimes we'll give them bicarb to help out with that. Typically they're very fluid depleted, so we're giving them lots of fluids, and we're giving them insulin as well, right? Not only that, we're giving them insulin, and we're also giving them some glucose as well. And you're like, well, why would you give them glucose? Their sugar is already like 400 or 500. Well, because they need glucose to get shuttled into those cells, otherwise they can run into some issues. But yeah, that's another big indication. We'll do like IV infusions of insulin in order to help get their sugars back under control and have them switch over from that fatty acid oxidation back to metabolizing carbohydrates, right? Occasionally we'll find type 2 diabetic patients will develop this hyperglycemic, hyperosmolar, non-ketotic syndrome. It's kind of like their version of DKA. I mean, you can see sugars like up in like, the 600-700s in some cases there. They get very hyperglycemic, but not usually acidotic. So it's a different kind of pathophysiology, which I'm not going to delve into too much here. And then also we can use it for hyperkalemia. Why would I use this for hyperkalemia? This is one of those things that actually helps to shuttle potassium into the cell. And when we get into emergency medicine, we'll talk about hyperkalemia. And I had a recent report that one of our students did not know how to treat hyperkalemia. And I was very disheartened by that, because I know I teach all of you the same way every year. My videos will prove that that I taught hyperkalemia. So I'm going to make sure you guys know this when we get to the ER setting later on. But this is one of the drugs we'll give forward that will actually give them insulin to drive potassium into the cells. Okay, let's do a 10-minute break unless anyone has any questions. Then we'll come back and continue on. Oh, do you have a question?
Yeah.
Yes.
Sorry.
It's
So
okay.
when you see like,
Wait a second.
to make it simple, 10 units of insulin, like Lispro or something like that. Short acting.
Hold on, you guys wait a second. We're trying to answer a question, please. Thank you, thank you.
So when you see like give 10 units of insulin, is that just 1/10 of the U100 in like 1 milliliter, for example?
So it would be 0.1 ml
Right.
would be the amount, right? Because it's 100 units per ml. So if you said give 10 units, it'd be 0.1 ml. But you would say give 10 units. And the nice thing, those insulin syringes, they're designed with the units already on them. So instead of having like a volume, like a ml indications on the syringe, it would just say units. So you just draw back to 10 and you administer that. Yeah. All right, nothing else? We'll see you guys in 10 minutes. Continuing on, talking about our insulin regimens. So you'll find that this is like a big, especially if they're on insulin for all of their replacement needs, so like your type 1 diabetic patients, this is a big lifestyle change for them, obviously because they're having to inject themselves multiple times a day. And so it's really important that they are checking their glucose like they should be appropriately. It means a lot of finger sticks. It means a lot of, looking at the meals that they're intaking. We'll talk about carb counting and things like that a little bit later on. Ideally, once you get someone kind of settled on their insulin regimen and they're pretty tightly controlled, you'll see those are when patients will sometimes switch over to using sub-Q insulin pumps. But that can be really tough too, because imagine if someone's maybe not real compliant with their diet or with managing their insulin and they have this pump that's going 24/7. Could that be an issue perhaps? Either they are hyperglycemic, hypoglycemic, and actually pumps can break sometimes. I've had some kids who actually get admitted for hyperglycemia because their pump maybe stopped working, or maybe hypoglycemia because it was maybe giving too much. So as time goes on, those get better, and so hopefully you'll see less of those, but it can happen. And frequently you're trying to kind of balance between the number of injections. So obviously the more injections that you give, the tighter control on that glucose you're going to have, the more time you're going to spend keeping it right in range versus if you're giving it less often. It's better from a compliance standpoint, better from a quality of life standpoint, but you have less chance for hypoglycemia. Obviously, the more insulin you're giving, the more chances for hypoglycemia you run into, but you're going to have looser glycemic control. So you're going to have more vacillations between the peaks and valleys in terms of their glucose levels, right? And again, how do you check to see sort of what the average glucose has been over, say, a long period of time? Yeah, so A1C can kind of tell you roughly like what their glycemic control has been like for a while. So for instance, you may have patients that are non-compliant and they'll come into the office and they'll take their insulin before they come see you, say, look, my glucose is fine. And they check the A1C and realize it's like, 9 or 10 or something, and you realize, oh, you have not been all that compliant, have you? And so you're going to see that they need to match their carbohydrate intake along with their physical activity. So for instance, if they're being physically active, they're going to go work out, they need more or less insulin, do you think? Actually need less in those cases there, right? Because they're utilizing that glucose for actual energy expenditure for keeping those muscles moving, right? If they're going to eat like a big starchy meal, they're going to need more insulin in those cases to deal with that increase in carbohydrate intake. And so again, they'll get very good at this over time, hopefully, if they're staying compliant with their regimen, and they'll be able to predict a lot of that stuff. And again, every patient's going to respond a little differently, and we'll talk about something called like an insulin sensitivity factor, such that if I were to give each of you 1 unit of insulin, it would change your glucose by different amounts because you may have different varying insulin sensitivities, right? So some people, you may get more glucose, have a bigger glucose drop. Some people would have less depending on how much sensitivity you have to that. But what we tend to find is that a lot of times patients will not be able to suffice with just 2 times daily injections. Typically that's not going to be tight enough glycemic control just due to meal times in a lot of cases there. Obviously the ideal thing would be to have it mimic the pancreas as much as possible, which is what those subcutaneous pumps kind of do, which is nice because again you get that basal amount of insulin going 24/7, and then they have the bolus doses as needed around meal times though. Is anyone familiar with any other ways to check glucose in just a finger stick? Yeah, I had one student who's actually had a subcutaneous monitor is on the back of her arm, and she would be able to check her glucose just with that. It was actually Bluetooth connected. She could check on her phone. That one had an issue too because actually sub-Q glucose actually takes longer to equilibrate than what is actually in the bloodstream. So there were some downsides to it. It was usually lagging behind by like an hour or two from what her actual blood sugar was. But different ways, right? So ideally in the future we'll just have like implantable devices where you don't have to think about it. It's just like a robot pancreas that does all the work for you. So one day we'll get there, I hope. Maybe Tesla will do it for us, right? It'll be their next venture. But anyway, yeah, hopefully the pancreas doesn't catch fire like Teslas do. That would be bad. Anyway, so looking at this again, you'll see that when you have patients on insulin regimen, so again, let's say we're talking about type 1 diabetics where we're supplying all of their insulin needs. Again, they'll get usually like say, a one-time dose in the morning of say a long-acting insulin that will provide that basal coverage, and then they'll get mealtime insulin as well. So you may see they're on insulin glargine, so many ever units, one-time daily sub-Q, and then they'll have say insulin Lispro, a fast-acting insulin, TID with meals, right? And that way they can go ahead and administer those doses at mealtime, deal with that big influx of glucose, and hopefully keep their glycemic control pretty tight there. So you're going to see that, as I mentioned, looks like I repeated that slide. Oh no, it's a different slide. But you'll typically see long-acting insulins are either given in the morning or in the evening there. You're going to find that the ultra-rapid-acting insulins are usually taken around meal times, as I mentioned. And there's two main varieties you can do. So there's what we call like a sliding scale means of determining insulin needs, or you can do carb counting essentially, right? So when I say sliding scale, what do you think that means? It adjusts based off of what? What their current blood glucose is, right? So for instance, we do this a lot in the hospital where it'll say, hey, based off you take a blood sugar now, and based off what that scale is, if it's this many ever milligrams per deciliter, you give this many units of insulin. If it's higher than that, then you give this many units of insulin in order to get them down into range. So that's a common way to do that. Again, this is based off preprandial glucose readings. The downside though is it doesn't take into account the number of carbohydrates they're actually taking in there, right? What we will frequently see a lot of these patients do, at least on the outpatient side, is actual carb counting, where they will have a pretty good idea of what their insulin sensitivity factor is, such that they know if they get this many grams of carbohydrates coming in, they'll be able to account for how many units of insulin they're going to need based off of that. So it'll be basically this ratio they'll be able to calculate and determine how much insulin they're going to need, how many units they have to inject in order to counteract that. So they can actually look at the meal, determine how many carbohydrates are there, and then they'll be able to calculate their units of insulin. Like I said, I've seen 8, 9-year-olds are able to do this almost like intuitively, just because they kind of know it. They know what they like to eat, and they kind of get a feel for those meals, and they can figure out their insulin regimens like really quickly and pretty accurately for the most part. So these are some different ways you may actually administer insulin regimens. So for instance here, let's say we have like a normal plasma glucose concentrations. Again, basal glucose levels, which hopefully is not going to be 0, but maybe around 80 to 100. And you'll see here normal spikes in glucose due to meal times, right? So how could we, and again, here's what insulin release would look like as a result of that. So around mealtime, you have a big spike of glucose, you'd have a spike of insulin coming from the pancreas, right? Along with a basal amount of insulin throughout the day. So how could I mimic that with using different insulin regimens here? So let's say we're going to take one where we're using an NPH insulin plus regular insulin. So nothing extremely long acting, nothing extremely short acting. Here you could find I'd give a combination of the regular and the NPH insulin at the same time for morning. So that would deal with the morning time glucose along with the basal amount, because you notice the NPH is lasting roughly 12 hours or so. And then they would get a second injection right around dinner time, right? So again, 2 times injections, but what do you think would happen to their glycemic control? Be really tight or kind of loose? Pretty loose in those cases there, because again, we're not really seeing anything being given around lunchtime. You may be seeing the NPH kind of peaking at that point, but again, this is done as commonly as you'll see. What you see more frequently would be a long-acting insulin given in the morning that will provide basal amounts of insulin throughout the day, and then they'll get maybe a regular insulin around those meal times there to mimic that. So this way it'd probably be a 3 or 4 injection sort of day, so more injections, maybe more risk for hypoglycemia, but tighter glycemic control for those patients. And then you could actually just do the sub-Q continuous pump, where actually the pump itself will have a basal amounts releasing. It's almost like a PCA in how it's operating. We have a basal amount being given all the time, and then you'd have programmable doses that it could administer around those meal times, right? And that way it can provide the tightest control. But again, it's going to be the most kind of labor intensive. Again, patients need to be pretty well controlled before they can be trusted to use that pump themselves, right? What do you think is another risk of having an implanted sub-Q pump sitting there for a long time? Not the pump is implanted, but the actual catheter is sitting there for a while. Yeah, infection risk can be a big thing, right? So, but frequently the devices are made either they can like disconnect it for a short period of time, so they can take showers, keep it clean, things like that. They'll change it out regularly, so hopefully that won't be as big of a risk, right? Now, I'm not going to get into specifically how many units of insulin to dose a patient with. I think Professor Kaplan might get more into that. If he's alluded that to me, so you may see that when he gets into it. But I want you to at least know the sort of the reasons behind how we dose this stuff. So, what do you kind of notice between the number of units a type 1 diabetic patient would need in a day versus a type 2? Type 1 needs less. Why is that? They don't have any insulin resistance, so they should have very little insulin resistance as compared to your type 2 diabetic patient there. Typically what we do, we start, and again, this is a starter dose, so this would be how you'd initially start a patient, and then you adjust it based off of how they're responding. And again, you're checking all their glucose logs. Most of the glucometers will actually keep records, so it'll show you when and what levels they had throughout the day, so they actually keep track of that, or they may keep like a little diary where they mark that down. And so typically what we'll do is we'll take 50% of their dose, give it as a long-acting insulin. So maybe they get, say, insulin glargine or insulin detamir in the morning. And that may be just their one-time dose of their ultra long-acting. And then the other 50% is going to be broken up into their ultra or rapid-acting insulins. And that'll be around meal times, right? So basically you divvy this up. Now, when do patients probably get their biggest carbohydrate intake? I think lunch? Maybe breakfast. Probably, most people, I'd imagine breakfast, right? I mean, you think a lot of breakfast foods tend to be high carb, right? Maybe a light salad for lunch. It depends on the patient, right? So again, you may adjust. I guess I just think about breakfast as being for carbs. At least that is for little children. I make pancakes for them, and I make cereal for sure. You know, a lot of milk. You know. Anyway, point being, it may be different for each patient. So when do they have the most carbohydrates in their food? Then you'd adjust it for that basically, right? So for example, if I were starting out a patient, say they're 40 kilos with type 1 diabetes, I'd basically say, well, what's their total insulin dose for the day? And so I'd start off maybe on the low end, and I'd say half a unit per kilo per day. So I'd multiply that out. So they should get 20 units throughout the day, right? So 50% of that will be their basal. And so maybe I'll do insulin detamir twice a day, or you could just do 10 units in the morning, and that would be perfectly reasonable as well, right? So that's 50% of their total daily dose as their basal. And then not the herb, but their basal amount of insulin. But then the other 50%, you then break it down into kind of where the carbohydrate intake is going to be coming in. So again, imagine they're eating 3 meals a day, maybe 20% at breakfast, so they get 4 units of insulin Lispro sub-Q with breakfast. They get say 3 units at lunch, and then 3 units at dinner, right? And again, this is just a straight, not carb counting, not doing anything like that. You'll find that as you get more into doing the calculations, and this is where your endocrinologists really come into play and can help out a lot with that. They can help make more patient-specific adjustments to see how they're responding to this. But this may be like an initial thing they'd start out with, okay? And again, all your patients, you'll find they are all individualized. They all are snowflakes in the non-derogatory sort of sense, but they will all act a little bit differently depending on the situation. And again, think about it. If they get sick, if they get an illness, that can change how they're going to be processing glucose. Typically, illness will do what to your glucose levels? Body's kind of stressed out, probably raise it, right? So then maybe you need to adjust their insulin levels based off of the illness that they're experiencing, right? That could be a reason why they're coming in for hyperglycemia, is because, you know, that viral or bacterial illness, right? So as I mentioned, insulin pumps are nice because they help to basically replace what the pancreas would normally be doing throughout the day. But make sure that patients are, cognizant enough to be able to calculate the pump, how much they need in terms of their basal amount, how much they're going to bolus in based off their carb counting and their insulin sensitivity ratios and all of that. So there's a lot of training. This is where your diabetic educators are absolutely invaluable. Those are amazing people who know everything about the disease state and how to manage it, and they're really, really helpful. And be aware of the pump malfunctions, how that can lead to hypoglycemia, and it could be a reason for an admission potentially if that's not identified as that's the cause for it. Okay. So what do I do if they're hypoglycemic? Let's say we screwed up and we accidentally gave them too much too much insulin, and now they're hypoglycemic. So for one, you want to make sure they know the signs and symptoms, right? So what would you expect to see with a hypoglycemic patient? You get shaky, you get a little tremulous. How about the heart rate? Right, kind of tachycardic. What else? Start sweating a little bit. How's their mood? They're hangry, right? You seen that Betty White Snickers commercial? Kind of like that. They get real hangry, kind of grumpy. What could that lead to eventually? They get worsened hypoglycemia. Altered mental status, all the way up to seizures. Yeah, if the brain's running out of glucose to run off of, you can see seizures. And that could be one of the big things. If you have a patient who's coming in for a seizure, one of the first things you always check is the bedside glucose, right? Because it's the easy thing to determine if it's low or not. And if that's the case, then it's an easy thing to replace, as you'll see. Okay. So anyway, but we consider anything less than, say, 65 to 70 milligrams per deciliter or so to be considered to be hypoglycemic. Again, different patients may respond at different levels in terms of their symptomatology there. A lot of times what patients will end up doing is they end up overcorrecting. So if they get that kind of hangry feeling, they'll end up kind of overdoing it, taking in too many carbs, and now they have hyperglycemia to deal with, right? So in general, one of the kind of rules you'll see there, and ideally if a patient is still with it, they're still cognizant, we can go ahead and try giving them oral supplementation. That's kind of the easiest thing to do for them, taking oral glucose. So what we can do is give them the rule of 15, which is basically 15 grams of simple carbohydrates. I say simple, what does that mean? Kind of shorter sugar molecules. They're easy to break down and absorb very quickly, right? So this is not like, have a bowl of oatmeal. Like, those are pretty complex carbohydrates as opposed to like, I don't know, like glucose tablets or something where it's just the straight glucose itself. Anyway, so that could be like 8 ounces of orange juice. It could be 8 ounces of milk. Maybe 4 glucose tablets is typically a standard dose for that. And then they will recheck their glucose in 15 minutes. And if it's still less than 70, then they can repeat that. Again, that avoids having to overcorrect and causing the hyperglycemia there. So that's all well and good, but what if your patient can't take anything orally? What do we do? I'm going to inject them, perhaps. Let's say they're unconscious, right? Let's say they're not able to take anything orally. This is where we can get into some our parenteral medications here. So very frequently you'll see this, is that patients, at least when they're getting a new onset or new diagnosis, they will definitely get a prescription for a glucagon pen or a glucagon injection to go along with that. It's kind of like having an EpiPen if you're diagnosed with having anaphylaxis to say nuts or something, right? They should have this available to them in case they get hypoglycemic. And of course, are they going to be the ones injecting themselves with this? No, because they're probably unconscious at the time, right? But glucagon is going to do what for us? It's going to stimulate the liver to break down the glycogen, undergo gluconeogenesis, and then it'll raise up those blood glucose levels, right? Back that we can supply the brain more glucose, can start to operate again, right? You'll also find there's some other uses for glucagon as well. We actually can use this occasionally to actually help with foreign body passages. So you guys are covering peds. GI stuff with Professor Sales. Have you covered any like foreign body ingestions?
Yes.
Yeah, like what are some bad ones? Coins can be okay. So coins can be bad if they get stuck in the esophagus, right? So sometimes though, if it's a small enough coin and a big enough child, you don't necessarily have to worry about it. But I do tell patients, like if they, like the kid ingests a quarter, like how do you tell them to monitor for it? You got to check the stool, right, to make sure it comes out. But I say the only time you have to worry about it is if it comes out 2 dimes and a nickel. Okay. No. Anyway. But other things that can be really bad are those disc batteries as well. Those can be pretty significant. Can actually lead to esophageal perforation. Can be a significant caustic injury to the esophagus. But sometimes we'll actually do, if there's a foreign body ingested and we can visualize it, you'll see this a lot like overnights when the GI docs don't want to come in. It's like give them a dose of glucagon. And one of the things it actually does is it help loosen up the lower esophageal sphincter and aids with the passing. So you can give them a dose of glucagon, wait for a little bit, come back and do another x-ray and see if it's passed into the stomach. And for a lot of things, once it's in the stomach, then it can just go through with no problems there. What's another really bad ingestion for foreign bodies? Safety pins usually aren't a problem. Usually they're closed for the most part. I haven't seen that be too big of an issue. Magnets can be really bad. You ever seen those buckyball toys? Those can be really, really significantly bad. The one magnet by itself is not bad. It's when you get 2 different magnets that are maybe separated out, or a piece of metal and magnet. Guess what happens? And there's usually a lot of GI material in between there, and guess what? They perforate right through. So there's been some pretty bad cases with that as well. So, and with little kids, they want to tell you when they ingested something. Not typically, right? So I had one kid who had, he was probably like 6 or 7, had accidentally ingested a disc battery. He was like kind of playing around with it in his mouth and swallowed it on accident, and probably waited at least like maybe like 3 or 4 hours, like past when he probably should have, until he started to get kind of GERD-like symptoms. And mom was like, what the heck's going on? And he finally fessed up to it because again, he doesn't want to get in trouble. All those cases there. I'm starting to see that too. Actually, my wife caught my little one, my 2-year-old, actually getting like falling to the ground. She's like, what the heck happened out in the backyard? And then she sees that her big sister had pushed her. And so she goes, what'd you do? And she's like, I want to go play over here. And my wife was like, no, did you push your sister? And she's like, and then slumped her shoulders and she got caught, right? So, but anywho, so you may see glucagon being used occasionally to try to aid that foreign body passage through the lower esophageal sphincter. I don't find it's all that effective, but that's something you may see like in the ER sort of setting there. Far and away, the most common thing you're going to use it for is for the hypoglycemia. It doesn't work always, especially if the liver is kind of depleted of glycogen stores. So if you had someone maybe who's been fasting for a while, or someone who's maybe been hypoglycemic for a long period of time, they may have already burned through that glycogen. This isn't going to be all that effective because there's no glycogen for it to release, to turn into glucose, right? Another big thing you're going to see with glucagon is it causes a significant nausea and vomiting, so definitely make sure you're pre-medicating with some Zofran and watch out for that, okay? So if that doesn't work, or maybe I don't have it available for whatever reason, glucagon is actually pretty expensive because again, it's a protein you have to administer there. We can just do straight dextrose, right? And so we would typically administer this intravenously, and there's different concentrations that you can give, right? So for instance, there's like D10, D25, D50 is probably the most common one you'd find in the code cart. And typically what we're going to be doing is giving typical doses like 0.5 to 1 gram per kilo, usually around 25 grams or so at a time. So it kind of comports with the 15 grams you saw in that rule of 15. So we'll give them 25 because again, they're unconscious. They probably need more glucose to get back to normal there. The big issues you run into in terms of glucose and the concentrations is going to be that the higher the concentration, the harder it is on the veins. And so we typically find that like for especially little kids that have smaller, more delicate veins, that we are limited in how much glucose concentration we can give them. So we'll give them D10 or something. In some cases, but if it's like an adult patient and they're like unconscious, then we may just give them D50. Like we know the veins might be a little sore, but it's better than the patient being like dead, right? So in terms of that, what do I have to change? If I'm giving a lower concentration, but I want to give the same amount of dextrose, what do I have to change? The volume I'm giving, right? So again, you may find that the dosing is going to be based off mLs per kilo, and so that'll change based on the concentration you're giving. So you may see that occasionally, okay? So, and again, based on your patients, the treatment goals may differ depending on kind of which guidelines you're going over. Let's say we're talking about like type 2 diabetic patients now, like shooting for A1Cs maybe less than 7%, maybe less than 6.5. Again, whatever the goals for the patient are, we're going to look at the meds that we can actually use to get them under control, whether it be with insulin alone or whether we're going to use some of our oral medications to get them under control if they say, for instance, have type 2 diabetes. So let's say we have a type 2 diabetic patient. Once we make the diagnosis, we will then focus on lifestyle changes, right? Are those always effective? 100% of the time they are. It's great. Stay. Get out there, start exercising more, start eating a low-carb diet, and they're good to go, right? Unfortunately, no, right? We'll focus on monotherapy, typically with an oral agent, and if that's not working, we'll look at combination of oral medications. And then if that's not working, that's when we start to consider adding on insulin, okay? So insulin really should be a last resort for these patients. We have several different options though on that way, in order to try them out and see if we can get them under control before we need to start injecting the patient, okay? And so what you're gonna find is, imagine you have a patient, and I kind of like these slides because they kind of illustrate the changes that occur with patients either that have normal glucose tolerance, if they have impaired glucose tolerance, or if they have type 2 diabetes. They have full-blown diabetes here. So looking at their plasma glucose levels and their plasma insulin levels, it's really kind of interesting to look at the differences here. So let's say, for instance, we gave them a glucose bolus. And so what do you notice about, say, the plasma glucose levels? Well, they go up, right? And who do you expect to have the highest glucose in response to that glucose bolus? Probably the type 2 diabetic patients. That's not all that too interesting, right? Because that kind of makes sense based off what we know. What is kind of interesting, I think, is going to be the insulin response here. Because again, you're given a bolus of glucose, you'd expect insulin to go up. And that does make sense based off the normal glucose tolerance. You see here with the impaired glucose tolerance, they have a higher response. Why do you think they have a higher response than the normal glucose tolerance? They have more resistance to it, right? So they need a bigger dose of insulin in order to get that same glucose into the cells, right? But what do you notice about the patient with type 2 diabetes? They can't mount the same response as someone with impaired glucose tolerance because they've basically started to wear out the pancreas. So even though they need a bigger dose, they can't supply it anymore. So it kind of goes to show you that not only is it a fact that they are insulin resistant, but they may end up being insulin deficient as well as time goes on. And so we'll look at some ways we can help to deal with that, okay? Other things you're gonna see here as well is gonna be the changes in glucagon secretion as well. So let's say we have the same sort of challenge. We're gonna give the patient a glucose bolus and see how that responds. So normal glucose tolerance is going to be the green line here. The kind of orangey yellow line is going to be type 2 diabetic patient. Notice here their insulin secretion is going to be much higher because again that type 2 diabetic patient just doesn't have the same kind of insulin producing ability anymore. The pancreas is starting to wear out. But then what do you also notice about the glucagon in the normal glucose tolerance patient? If I give them a glucose bolus, what you would expect to happen, the glucagon goes down, right? But what do you notice here in the type 2 diabetic patient? It stays up. So what does that do to your glucose even further? Rise it even up higher because it's still telling the liver to, hey, send out more glucose, even though it doesn't actually need it. So there's a lot of problems here. Not only is it due to insulin resistance, insulin maybe deficiency, but it also has to do with things like glucagon response and some other hormones we're going to look at. So not great, right? So let's look at our different classes of medications that we can administer to overcome this, and right? So we're going to talk about things that may either increase insulin secretion. In this case here, we're going to look at our sulfonylureas or meglitinides. So again, if the problem is we're not releasing enough insulin, well, let's give them something to cause more insulin to be released. Okay, so we can do that. We'll get into drugs that try to sensitize the body. So I say it will allow our body to uptake that glucose more readily than it would otherwise. So these are insulin sensitizers. They can also work on things like hepatic glucose production to drop that down somewhat. And this will include our thiazoledinediones. It's kind of a mouthful. Just say TZDs. It's the easier way to say it. And then our biguanides. Anyone know which drug fits into biguanide? Yes, metformin is going to fall into that category. So this is going to be our kind of gold standard starter drug, as we'll see in just a little bit. Well, what other ways could we affect glucose? Well, what if we didn't absorb as much glucose from the GI tract when we take our meals? Well, we can have drugs that will actually block an enzyme called alpha glucosidase could help out with that, such that blood glucose should not rise as high because we're not absorbing as much. And we'll see there's some issues with that. And then we're going to have some things that can suppress glucagon. By suppressing glucagon and decreasing gastric emptying, we'll also see there's some effects on satiety as well, right? Satiety meaning hunger, right? So if I have less, or if I decrease my food intake, it's usually because I have a higher satiety, right? I feel full. So we're going to find there's some ways to deal with that. And then there's going to be a new way. The newest set of drugs we have here is what we're actually going to have is these SLG2 or GT2 inhibitors. And that's actually kind of a novel way. And basically, we're just going to cause the patient to pee out more glucose. Now, typically a diabetic patient, what happens to their glucose when levels are high? Where does it get excreted through? Kidneys, right? So UA is usually frequently done in these patients. You normally would see glucose being spilled out into the urine because it overwhelms the capacity to reabsorb it in the proximal tubule. We can give them drugs to actually cause them to pee out even more glucose. And also look at some unique sort of issues with that as well. So a lot of different ways to affect this, right? And again, these are big dollar sort of medications because are there a lot of people with diabetes? So if you can make a drug for it and give it to lots of millions of people, guess what? You can make lots of money. So you'll see a lot of these medications come out. This is why you see a lot more new drugs coming out for diabetes than you do for, say, infectious disease, because it's a lot bigger money maker, as you might imagine. So, and just to give you some ideas, sort of the relative efficacy between these different agents here, you can see what sort of effects it would have on, say, fasting plasma glucose and also on A1C reduction, right? And again, usually seeing, say, a 1 percentage point on A1C is equated to about how much milligrams per deciliter of glucose? Anyone know? It's about 35 or so, about 35 milligrams per deciliter. And so if you drop down your percentage point on your A1C by 1, you typically drop your average glucose level by about 35 milligrams per deciliter. It's kind of a rough estimate. But you can kind of see here how that would kind of work out in terms of how well they're going to work. Not all of these are going to be as equally effective as one another, and we're also going to see we can use them together to get some better synergy by working with different mechanisms, okay? So starting off, let's look at our sulfonylureas, or our oral hypoglycemic agents. These are going to be drugs that directly stimulate the pancreas to release more insulin. And it's going to go back to that process we talked about in the first hour on how we normally release insulin in response to glucose. Okay, we have some first agent ones here that don't get as much use anymore. Probably chlorpropamide is probably the most common one you'd run into. But the second generation ones you're going to see are going to be much more potent, fewer side effects, which is nice. And these ones you do see very frequently. So glimepiride, glipizide, and glyburide for sure. Okay, so like we were talking about insulin released normally, remember how glucose comes in, turns into ATP, and then closes off those potassium channels, causes calcium to flow in as the cell depolarizes and insulin releases. Well, the sulfonylureas just come in here and just say, well, forget the glucose, let's just go ahead and close off these channels ourselves, causing that depolarization, and then thus more insulin gets released. Okay, so just based off of that, what do you think is the most common side effect you run into with the sulfonylureas? Hypoglycemia, right? What else would happen as a result of all that insulin being released? How about their weight? It's going to go up. So this is a definite class of medications that may not be great for patients already overweight, because it's going to cause their weight to go up even further, right? Just like insulin would cause it to occur, this will do the same thing, right? So basically, this is the main way it's going to do that. By releasing more of the insulin, you will also try to decrease hepatic production of glucose, because that should help to shut that down to some degree. And overall, you may find some increase in insulin receptor activity, but it's not going to be as probably as one of the most efficient manners here. The big thing is just directly releasing more insulin directly from the pancreas. Do you think these things are bad in overdose, or not too bad? These can be pretty bad. Actually, I have to, if you see like a kid get into like a glyburide or glipizide or something, especially the XL formulations, they can have this recurrent hypoglycemia that's even like 18 hours out after the dose. They can still end up on a D25 drip in some cases in order to manage that. It can be pretty bad. So most of these are going to be pretty well extensively metabolized in the liver. Not a ton of like drug interactions from a metabolism standpoint though, which is fortunate here. But you do want to be cautious in patients who do have renal impairment, because remember, all that insulin you're releasing, part of that gets released through the kidneys. And so if you have poor kidney function, all that insulin is going to stick around. So hypoglycemia may be a bigger risk there. Also, you're going to find that many of these drugs are not suitable for pregnant patients. In this case here, we don't like this group because it can actually cross the placenta and actually deplete insulin from the fetus. So that can actually cause the diabetes in that patient from that mechanism there. So this one would not be recommended for pregnant patients. So, and again, with these medications, due to their propensity to cause hypoglycemia, you do want to be cautious in elderly patients because they may be more prone to that. They may also have less sort of glycogen stores depending on their situation, so you want to be cautious there, okay? Also, chlorpropamide is kind of unique because it causes the disulfiram reaction. You guys remember what that was? What was that reaction? You drink alcohol and what happens? You get flushed, and you get hot, you get sweaty, and you feel really miserable, right? So that antabuse or disulfirams. What other drug caused that? Metronidazole or flagerite. That will probably end up on your board somewhere if I had to guess. It's a classic question, right? But you're going to find some of the newer agents, the second gens, are going to be less likely to cause the hypoglycemia, which is beneficial there. So again, these can be quite effective though, helping to get the glucose under control. It's just the fact that due to the weight gain, due to the fact that they do have that risk for hypoglycemia, these probably aren't the first set of drugs you're going to put a type 2 diabetic patient on. This might be a good add-on though. It might be a good second line sort of agent to help out with that, right? And again, you got to educate what to look out for with hypoglycemia. Make sure they have glucose tablets available if they need that, or glucagon potentially, depending on how at risk they are. Here you're going to find, for instance, here like glipizide. It's nice if you have things that are long acting, because what's that going to do for compliance? It's going to help out, right? So actually, Glucotrol XL is a really interesting one. If you look up a picture of it, it looks like a normal tablet, but the tablet itself doesn't break up in the GI tract. What it actually has is a tiny hole drilled into it, and via osmotic pressure in the GI tract will actually cause drug to be slowly released out throughout the period until it gets pooped out. And then so patients may actually report, they'll see that tablet in their feces, and they'll think, well, the drug didn't work. So when it was working the whole time, it's just that tablet's not meant to actually dissolve and be broken down. So a little unique counseling point for that particular drug. But again, just be aware of the fact that the hypoglycemia is the big risk with these ones. And again, using the XL formulations is nice from a compliance standpoint because these patients probably are on a bunch of other meds already anyway. So we mentioned weight gain, mentioned the hypoglycemia. Other than that, fairly well tolerated for the most part. These are just kind of rare other effects you may see occasionally. And then you may also see resistance to these develop over time. And why do you think that would be? You're working the pancreas even harder than it was before, right? So you're kind of expediting that wear and tear on it. And so again, this may not be great in the long term. So you may see that the pancreas just can't respond as well anymore, and you get more resistant to it. So some contraindication to be cautious with, could you use these in a type 1 diabetic patient? Why not? There's no insulin to release, right? So it wouldn't actually do anything to them. We mentioned the pregnancy thing, it would be cautious with. And then, again, with these being highly protein bound, be cautious if you have any drugs that would actually knock them off, because again, you would see an enhanced hypoglycemic effect. So you would want to be cautious with that. And then anything that would be like glucocorticoids and other stuff we covered that's going to raise blood sugar will make these less effective, right? So those are things you'd want to be watching for. So kind of similar to the sulfonylurea. Oh, yes, ma'am. I don't know. There might be one or two of them that have like a sulfa group on them, but they're not like, they don't have the sulfa moiety like you would see with like a Bactrim or something like that. I'd have to check on the individual agent to actually look. I don't know if it's for every single one of them. There might be one or two, but I'd have to look. So I didn't mention it on the slide, so it's probably not that important from my standpoint. I don't know if that's important or not for you, but anyway. So kind of the cousins to the sulfonylureas are going to be the meglitinides. This includes repaglinide and then nateglinide. The nice thing with these is that they only work in response to high levels of glucose. So they don't work unless you're having, say, a mealtime bolus of glucose. So they work around mealtime. Should give it then. That ultimately makes it less likely to cause hypoglycemia than your sulfonylureas, but ultimately they're going to be less effective. So you're going to find that these are not used quite as often, but maybe second, third line medication you may add on in those cases there. But as I mentioned, you want to take it before mealtime because that's when the glucose is coming in, when the drugs are going to be that much more effective there. Again, typically you'd use this as an add-on, typically not monotherapy by itself. And again, if the patient misses a meal, go ahead and skip the dose because the drug's not really going to do a whole lot for them at that point, right? In terms of adverse effects, pretty similar to what you saw with the sulfonylureas, just a little bit less. So less weight gain, less hypoglycemia, but still risk you might want to watch out for. Okay, so next we have biguanides, or this is where metformin comes into play. So this is basically 9 times out of 10, if you have a type 2 diabetic patient, they're going to get started on metformin, right? There were other ones that were out there. So for instance, there's like buformin and fenformin. Actually, a lot of them got taken off the market due to a risk for causing lactic acidosis. And I only mention that because guess what metformin itself can also do? Cause a lactic acidosis. So this is going to be a caution you want to be seeing with your patients, especially those that may be at risk for that. I'll talk about some of those risks in just a few minutes here. Due to compliance sake, you'll frequently see metformin combined with other drugs. So you may see like a combination of metformin and glyburide or metformin and rosiglitazone, which is another class we'll talk about later on. But this is a frequent one you'd use as a cornerstone of sort of your therapy. This is the backbone of therapy. You can add other drugs onto if metformin itself does not provide sort of sufficient levels of glucose control for those patients. So how do the biguanides work? These are going to be pure insulin sensitizers. They don't do anything to actually cause insulin to be released any further than it would normally. It only helps them to use their insulin more efficiently. So in these cases here, you'll find that hepatic glucose production will decrease, so they don't produce as much glucose in the first place from the liver. You're going to find that they will actually have better uptake in the peripheral cells of that glucose, such that they're taken away from the bloodstream. And so basically this is that tissue insulin sensitivity. It's making your insulin that you're already producing work that much better in those cases. And you may actually have a little bit less absorbed from the GI tract. So again, overall, less glucose coming into the system in general. The nice thing here with these drugs is that for the most part, they have very limited to no hypoglycemia that they'll cause. So that's a big benefit here. And do you think this would cause increases in weight? Not really, which is really nice from that standpoint. It tends to be weight neutral. To actually may lose a little bit of weight on these drugs. Another benefit of why we start patients on this one to begin with, because we mentioned a lot of these patients tend to be overweight. So looking at this, the kinetics itself, you're going to find that it's not metabolized in the liver necessarily, but we do want to be cautious because metformin can stimulate production of lactic acid, and lactic acid gets metabolized through the liver. So if you have a patient who has poor liver function, they're not going to be able to process that, and that could lead to a lactic acidosis, which has been fatal. I've seen a few cases of that before. You'll typically find that this is going to be eliminated in the kidneys, but if it's not eliminated due to kidney dysfunction, then you're going to find that the risk for lactic acidosis also goes up. So poor kidney function, poor hepatic function, metformin is not going to be a good drug for those patients, right? And in fact, there used to be actual creatinine clearance. There used to be creatinine levels you would not give metformin if their patient was above that. Now it's just basically saying at certain creatinine clearance levels, you don't want to use it. I'll mention that in just a moment here. But good for patients, especially if they're overweight, especially if they have significant insulin resistance. This is going to be the drug for them. And so, like I said, 9 times out of 10, you'll probably start them on one of these. In terms of adverse effects, the biggest one is just GI effects. So definitely a lot of diarrhea, a lot of heartburn associated with it. It's pretty rough on the stomach. And so sometimes what we'll do is use an extended release preparation such that you may help to mitigate some of that. But some patients are just going to have a rough time with this one from that standpoint. Maybe eating with meals can kind of help out a little bit, but it's just rough on the stomach. As I mentioned, patients who are on metformin are at that increased risk for lactic acidosis. We frequently see this as an issue of as they're getting older, and maybe no one's watching their creatinine clearance being an issue, maybe after surgery, or I think we talked about this in one of the grand rounds. Remember we talked about getting a patient who needed to go to CT, they might need contrast, and being on metformin. What was the risk there? Something called contrast-induced nephropathy that can occur where you can actually cause an acute decrease in kidney function such that you hold on to all that metformin, and that can increase that risk for lactic acidosis. I've seen a case where a elderly lady actually died from the fact that she got the contrast, no one told her to stop taking her metformin, came in severely acidotic, her lactate was through the roof, ended up succumbing to that. So it's certainly a risk you want to be cautious with, which is why, especially if it's a planned thing, you can say, okay, well, let's go ahead and hold the metformin for 2 days if we can, 2 days before, maybe 2 days after. You can deal with high glucose, but you can't really deal with that lactic acidosis once it kind of develops there. So those are the risks I worry most about with metformin. GI effects and lactic acidosis. You may see some impaired B12 absorption, so anemias can be another risk as well, but it's fairly low risk. So as I mentioned, the creatinine clearance here is important. If it's less than 30, do not want to use metformin at all, because again, lactic acidosis risk is going to be high. It's not that the metformin turns into lactic acid or anything, it's just it prevents you from processing that lactic acid in the liver itself. If they're already acidotic, if they have hepatic disease, things that would impair it from being excreted in the kidneys, in the renal tubules, you want to watch out for. And as I mentioned, should be stopped before surgery, at least 48 hours beforehand. And if you imagine, cutting into a patient, that can actually cause light lactic acidosis anyway. So that is why we also want to be cautious of those patients going to surgery, because it can exacerbate that, right? So those are things you want to be cautious with. And again, most of the time you see patients who may come in, if they need surgery, we can stop them on their metformin, give them supplemental insulin until they're post-op, they're kind of stable, and then we can switch them back to the metformin. It's a common thing you might run into. So, any questions on metformin? All right, I don't think I'm going to belabor these points anymore, but let me see if there's any questions on the board. So nice, I usually let you guys go like 5 minutes early. I don't know why I do that. I already got a golden apple, so it's not like I'm trying to gear for another one. All right, no questions. I think your glucose levels are at all-time low anyway, so I'll let you go, and I'll see you next time.